want to say thanks to Joe and to Linda. The dental CME folks have been the groundbreakers as far as how to work with the university in this, and it's been really quite a pleasure. I will sometimes start these talks by asking people to talk to their neighbor about their own, how close this comes to their own families or their own friends. I won't do that today, but I know that all of us have these really powerful stories, and I think that it's really important that because we all have been affected by this, and I think the reason we're here is because I think we all can be part of the cure. So we've been at this for a while. We're really pleased with the progress, and I want to review some of the information and turn it over to Sarah to get into some of the details, and then to Dana to talk about some of the public health parts of this. It's really exciting to be here, and thank you for getting up early. So today we're going to talk about the Opioid Prescribing Improvement Program, which is the program we're running at the Department of Human Services. We're going to overview the prescribing guidelines that are part of that, and the upcoming quality improvement part of that program. And then we're going to talk about some of the broader statewide efforts that Dana, myself, Sarah, and Linda are involved in, and we hope to have all of you involved in as well. First, no medical talk all medical talks must start with data, so I think you will, but I think this is I won't do too much of this, but I want you to know and see this. We had, in 2017, 401 opioid-related deaths. They are over half of the drug-related deaths in the state of Minnesota. And you'll see at the second circle down that synthetic opioids, which is the fentanyl and fentanyl analogs, are the deaths that are on the rise. We're pleased a little bit with the green line, but we really want to make sure that, which really represents the prescribed opioids. But remember, I think the crucial thing here is that virtually everyone who starts taking fentanyl or heroin starts with prescribed opioid pills that they either got themselves or they got through somebody who's diverting their own prescribed medications. This looks at our prescribing rate, and I think that this is really important. These are counties, and this looks at how many prescriptions go out the door per 100 citizens in that county. And you'll see that in a whole slew of counties that are in the tan, we're under 57, and in one county we're over 112 prescriptions. So there's a lot of variability in prescribing and prescribing culture in different parts of the state. And overall, Minnesota is lower than other states in the amount that gets prescribed, which is good. But the variability by geography is here, and Sarah will talk in a little bit about the variability by inside each type of prescriber by specialty. We started this program with one theme, and I think this is it, that our stand is only effective if we take it together. And we need all of our prescribers across the whole state and this whole community to be able to give the same messages to our citizens about how we want to help them with pain, but how we want to be very careful about their use of opioids. That's really the message that needs to get out, and the message we're coming to you with today. So when we started this, we started looking at some data about how to prevent chronic use, and this is all predicated on one simple but important fact, and that's that there's no credible data that says that chronic opioids are effective for chronic pain. That is really the thing that we've been sold for 20 years or so, but there's really, and everybody has personal experience about, or somebody who says they know how to do this, but if you look at the data on chronic opioids, there's really, and comparative data, there's often worse side effects. Aaron Krebs just published a major study out of our VA, or they're or there's just a lack of longitudinal data that looks for a long time and says that chronic opioids are effective. That's a hard thing to tell patients who are on chronic opioids, but I think the reality is that our goal then was to say, we need to make sure we take care of the folks who are on chronic opioids, but we need to prevent new chronic use. And so we actually looked at this and tried to develop a measure, and we did develop a measure of new chronic use that's really a symptom level measure. And what we really wanted to look at is what happens in a period of time after the first prescription and before chronic use. So there's a period that we've called the post-acute period, which is that time before 45 days and after the first prescription, where people shift to becoming chronic users. We wanted to evaluate prescription opioid utilization, prevent that progression, and identify an early inflection point. So we looked at this measure, and this is what we came up with in the Minnesota healthcare programs. These are patients who were opiate naive, which meant that they never had an opiate for 90 days before this time period, and then had opiates for 45 out of 90 days after the first prescription. And these are the numbers, the raw numbers of folks in the Medicaid program who once exposed became chronic users. And this represents about 1% of our population every year was going from being opiate naive to being opiate chronic users. If you look at this in a different way and look at how many people who got an opiate prescription then became a chronic user, that number is around 5%, which means that everybody, if you write a prescription for an opiate, you have a 1 in 20 chance of that person still being on opiates and becoming a chronic user. That's what we really want to prevent. The second thing we did with this data is we looked at how many of these folks, when we looked back, had a history of mental illness or substance abuse. And you can see that 81% of the people who were new chronic users had a mental health condition that was in our chart that we could find. 30% had a past substance abuse history, and 29% had both. So you can see that not only are we giving these out sometimes to people that we're concerned about, just in general, but we also know that we may be treating some other, it's possible we're treating some other mental health or substance abuse disorder inappropriately. So we developed, through legislation, the Opioid Prescribing Improvement Program. It involves these components, common protocols that, and Sarah will talk in a lot more detail about these, common measures of prescribing, common messages for providers, for you, and then hopefully for you all to give to your patients. And then we have some policy levers around quality improvement. The Prescribing Improvement Program was based on work that we did through the Health Services Advisory Committee. That's our committee at the Department of Human Services that advises the Commissioner on medical content. It was authorized during the 2015 legislation. Importantly, it does not apply to hospice or cancer pain. We're not trying to, we want to make sure that folks who are in those situations this is not applied to. And an expert community advisory group was convened to develop the program components, which we call the OPWG. From the dental school, Richard Nadeau has been serving on this committee since its inception. The committee is amazing because of the quality of the input, and also because the committee has maintained its attendance through 2 years of rigorous discussions. The OPWG is charged with developing the protocols, which are out and around. And Joe didn't mention this, but we have some podcasts and some CME with the medical school around the protocols. Developing sentinel measures for each prescribing period. So that is how we look at prescribing during the acute phase, during the post-acute phase, and then for chronic patients. Mandatory quality improvement for providers who are in the MHCP, in the Medicaid program, who exceed those limits. And the way this works is actually first, and this will happen shortly, there'll be a report put out But after the report's put out and a year later, if people still are way out of range, we've really tried to make the ranges wide enough, but still be clear. If people are still out of range, then we'll ask them to do quality improvement. And providers who are still out of range will not be able to participate in the Medicaid program. And then last, educational messages for providers. We really realized and we really heard that providers need to be able to know what to say and have these difficult conversations with their patients. So, a couple things. Why develop a new set of prescribing guidelines in Minnesota? And we thought, when we started this, we weren't sure how detailed we would need to be, and we realized after a while we needed to get into this. A few things. One is, nationally, this period, this inflection point that goes from acute to chronic is really not called out as a separate thing, and we really felt the need to call that out. So we really paid attention to when patients went from acute to chronic. We felt like we needed a state guidance that was local, that was responsive to the needs of our community. And then the guidelines really support the quality improvement process. So we really wanted to make sure that folks had guidelines that were focused and very specific to Minnesota that would support our program. So that's why we developed the guidelines. And now I'm going to turn it over to Sarah, who's going to go over the guidelines, go over the data we have, and then talk about the measures. And again, thank you for being here this morning.
Good morning. I think I drew the short end of the stick by having to do the details of the data at 7 a.m., but we will get through it. So first I would like to just lay out the key principles that underpin the prescribing recommendations. So for the acute pain phase, it is to prescribe the lowest effective dose and duration of opioid analgesia when indicated for acute pain. In the post-acute pain phase, which is that time period up to 45 days, the focus of the recommendations is to really use that time to halt progression from acute pain to chronic pain. And both of the recommendations look at increasing assessment of the risk factors for chronic pain and chronic opioid use. And then finally, for the chronic pain section, the recommendations really stress avoid initiating chronic opioid therapy for new chronic pain patients. But for those patients who are on chronic opioid therapy, the recommendations look at how to safely manage their opioid use over time. So I think everyone's familiar with the opioid crisis and the numerous factors that have led to where we are today. But I think what's important to remember is that the medical and dental professionals have a really important role in mitigating risk and exposure to opioids, particularly among some subgroups. Dentists are the top prescribers for adolescents, so individuals aged 10 to 19 years old. And I think what's really striking is evidence that came out of a recent study that adolescents who are prescribed opioids are 33% more likely to misuse opioids later in life, and those are opioids that are prescribed for a legitimate reason. And the other part of this is that a significant proportion of opioids prescribed to children and adolescents following an elective ambulatory surgery go unused. And it's that leftover opioid prescription that really contributes to misuse and non-medical use. So getting into the recommendations for acute pain, the first recommendation is to use multimodal non-opioid analgesia as the first line of drug therapy. And this recommendation is consistent with the ADA recommendations and the CDC recommendations that came out in 2016. I think that you're all probably very familiar with this, but non-opioid analgesics have shown to be an effective alternative pain management, and especially for research around oral surgery, NSAIDs and acetaminophen show effective pain management. However, it should be noted that the non-opioid analgesics certainly carry their own risk, and it is the provider's responsibility to know the patient's medical history and the risk of those treatments. So for patients who receive opioids for acute pain, the first set of recommendations is really looking at patient safety and screening for appropriate use. So the first recommendation is to query the prescription monitoring program when prescribing opioid therapy for acute pain. To know the status of your patient's risk factors for opioid-related harm, the Institute for Clinical Systems Improvement has a very clever mnemonic, ABCDPQRS, that addresses some of those risk factors. And so it stands for alcohol and benzodiazepine use, clearance and metabolism issues, delirium, dementia, and falls risks, the PMP obviously, pregnancy risk, and respiratory infections and psychiatric comorbidities. So just have a general awareness of those risk factors for your patients. And then another recommendation that came out of the opioid prescribing work group was to assess and document suicidality in every setting for every initial opioid prescription. Moving on to the dose limits, the recommendation is consistent with many other guidelines, both national and state, and that is to avoid prescribing more than 100 morphine milligram equivalents of low-dose short-acting opioids. And in our guidelines, we state to limit the initial acute prescription for more extensive surgical procedures or trauma to 200 morphine milligram equivalents. And then moving on, I think this is a really important area, and it looks at prescribing opioids for acute pain to patients with substance use disorder. And the general recommendation is to avoid doing so. So to either those with an active substance use disorder or to those with a history of substance use disorder. And for patients who have an acute pain incident that requires opioids and are receiving treatment for their opioid use disorder, to consult with the provider of their evidence-based treatment. This is another recommendation that the work group felt very strongly about putting forward, and that's for prescribing to patients who use chronic opioid therapy. And so the recommendation is to use the recommended dose and duration limit applicable to everyone, so 100 morphine milligram equivalents. But for patients who are on either very high-risk daily doses of chronic opioid therapy, the recommendation is to work in collaboration with their chronic opioid prescriber when they experience an acute event that requires opioid therapy. Now I want to turn away from the recommendations and look at some of the evidence that the work group used to make their recommendations. So this study was published last summer in the CDC Morbidity and Mortality Weekly Report, and it looked at the characteristics of initial opioid prescriptions and the probability of continued use both at 1 year and 3 years. So this study had 3 major findings. The first was that the probability of continued use depended on the initial total days supply. So the study found that at day 5 and day 31 of opioid use for acute pain, there was a significant probability of continued use at 1 year. The second finding, which I don't have the slide for, but it shows the same trend, is that the probability of continued use increases with the number of prescriptions. So approximately 1 in 7 patients who received a second prescription or had a refill were still using opioid therapy 1 year after the acute event. And the third finding, which the work group really spent some time with, was that the probability of continued opioid use depends on the initial total dose of opioid therapy. So on this chart, there's a circle, and it points to a point in the cumulative dose where there was a significant increase in the probability of long-term use. And this study found that happened at about 700 cumulative morphine milligram equivalents. There are other studies that have found that exposure between about 400 and 800 cumulative MME represents a significant risk, but this study pegged it at 700. And then moving away from that study, this is a study that was published about new persistent opioid use after surgery. It was also published last summer. And this study found that the incidence of new persistent opioid use after surgical procedures was between 6 and 6.5%. So this is important because this was much higher than any previously reported studies on new persistent use after surgeries. And one more study. Moving away from the incidence of long-term use, this looks at the population who's receiving opioid therapy. And this is really striking because it shows what we see in our own data is that patients with mental health conditions are much more likely to receive opioid therapy. Individuals with mental health disorders represent 16% of the population. They receive over 50% of illicit opioid prescriptions. So this really represents an opportunity to improve pain management for these populations, as well as to do a better job screening people before they make that incidental transition to chronic opioid use. Moving on to the post-acute pain phase, and again, this is the time frame where it's really important to halt the progression from acute opioid use to chronic opioid use. So these recommendations really stress looking at tissue healing in terms of continuing to prescribe opioid therapy. So to consider the presentation of pain in relationship to the tissue damage, and to not continue opioid therapies solely based on reports of improved function once the tissue healing is sufficient. And as we mentioned, this is the time frame where we really want to focus on increasing the screening and assessment of risk factors for chronic opioid use. So the recommendations provide a framework for increasing those assessments over time. And those risk factors include depression, anxiety, substance abuse, fear avoidance, and pain catastrophizing behaviors. And that all patients in this time frame who are receiving opioids should also be receiving multimodal therapies for pain management. And the recommended dose for this post-acute pain phase references back to the study that we looked at by Shah, and that's to avoid prescribing more than 700 cumulative morphine milligram equivalents in this time frame. And we're always very happy to see that Minnesota prescribers are doing very well in this incidence. We have another chart that shows that for internal medicine, which is one of the groups we've looked at for this data point, the bulk of prescribing is under 700 MME, and it's really just those outliers that are moving beyond prescribing more than 700 MME in the post-acute pain phase. Okay, I'm just going to touch on the clinical recommendations for chronic pain. We have data on prescribing to enrollees in the Minnesota Healthcare Program, and there are very few patients receiving chronic opioid therapy from dentists, which is a good thing. So just briefly, these recommendations really consistently follow the CDC recommendations that were put out in 2016. The work group used those recommendations to form the recommendations that are in the state guidelines. So the dose recommendation for this is consistent with the CDC to prescribe no more than 50 morphine milligram equivalents per day and to avoid going over 90 morphine milligram equivalents. That face-to-face visits should occur at least every 3 months. That risk mitigation strategies should be put in place for all patients receiving chronic opioid therapy. And those include things like pill count callbacks, routine urine drug screens, thorough assessments of mental health conditions to the duration of therapy, and then to address tapering and discontinuing therapy, both in advance of beginning or continuing chronic opioid therapy and with every dose increase. Okay. Moving on to the measures and the data. So as Dr. Schiff mentioned, another task charged to OPWG was to develop a set of measures that we could use to look at providers on an individual level to assess their prescribing behavior. So this is an overview of opioid prescribing data within the Medicaid program in 2017. There were just over 570,000 opioid prescriptions written. About 130,000 of those opioid prescriptions were in index opioid prescriptions, so a prescription written to someone who was previously opioid naive for 3 months. There were just over 260,000 opioid prescriptions that classify as opioid therapy based on our definition, and then about 180,000 other opioid prescriptions. So that's intermittent use or prescriptions written in that 45-day time frame. And just for some context, we have about 1.2 million enrollees in our program. The good news is that the total number of opioid prescriptions declined 17% from 2016 to 2017, and that's consistent with prescribing data that we're seeing around the country. And then looking specifically at dentists and oral surgeons. So the way that we classify our providers by specialty is using their NPI number and using the primary taxonomy code. So we've organized the dental providers into general dentists and then oral and maxillofacial surgeons and dentists who have a surgical indicator on their NPI. So for the general dentists, there were 13,000 index opioid prescriptions written last year, and then an additional about 4,400 prescriptions written in that post-acute time frame, and there were only 4 enrollees who received chronic opioid therapy from dental providers in 2017. And for oral and dental surgeons, there were 5,634 index opioid prescriptions, and then about an additional 1,200 prescriptions written in that post-acute time frame, and there were only 2 enrollees who received chronic opioid therapy. So this slide gives one visual. The information on the left hand of the slide are the 7 opioid prescribing sentinel measures developed by the opioid prescribing work group. It includes prescribing rate of index opioid prescriptions, the rate of prescribing over that recommended 100 or 200 MME dose limit, And then looking at the rate of prescribing over 700. So those are the first three, and those are bolded, and that's the data we'll look at in just a minute. And then the next four measures look at chronic opioid prescribing. So the rate of prescribing chronic opioid therapy, the rate of prescribing high-dose chronic opioid therapy, the rate of prescribing concomitant opioids and benzodiazepines, and then a prescriber that looks at, a measure that looks at how many prescribers an individual is receiving opioids from. And so these measures are all designed to be applied at the individual level. So in the triangle, it shows that at the bottom of our triangle, it's all of the individual provider level measures. And then we've made these measures available, and they can be run at a clinic or a system level. And then at the top of the triangle, which is the number that we're really trying to reduce, is the number of new chronic users in the Medicaid program. Okay. Now we're going to look at the data. And this is where copy is important. So this is the first measure, and this looks at the frequency of prescribing an index opioid prescription. So what we did for all the dentists, and I'll start with the dentists, and they're in the smaller circle, is we calculated a prescribing rate for each enrolled dentist who saw a Medicaid enrollee in 2017. So once we calculated a prescribing rate for all of the dentists who cared for our patients, we organized them into 4 equal groups. So we divided the group into quartiles. And so what this data shows, looking at the small circle that says dental general, there were 934 dentists who prescribed an index opioid prescription to someone, and the percent is the number of all of the Medicaid patients that the dentist saw, how many patients received an index opioid prescription. So starting in the dark blue bar, which is on the left-hand side, which represents the lowest quartile, at an individual level in that group, the median prescribing rate is 0.6%. So of the Medicaid enrollees that any individual prescriber saw, 0.6% received an index opioid prescription. And then you can see that the quartiles go up as the prescribing rate goes up through the quartiles. And so looking at the red, which is a little bit easier to see, this represents the highest quartile of dentists, and the median prescribing rate in that group is 13%. So of all the Medicaid enrollees that dentists in that quartile saw, the median rate was 13% received an index opioid prescription. Moving over to the larger circle is the oral and maxillofacial surgeons and the dentists who have a surgical indicator. You can see that the prescribing rates are much higher. In quartile 1, which represents the lowest prescribing rates of an index opioid prescription, the prescribing rate is 8.2, but then you see significant variability in the median prescribing rate in the highest quartile, so those dentists and oral surgeons who are prescribing the most. The percent of Medicaid enrollees who they saw who received an index opioid prescription was 66.7%. And this slide provides data for the emergency medicine providers for comparison to the dentists, who throughout the data and the analysis that we've done, the prescribing was very similar. And then for comparison to the surgeons, for the dental surgeons, our individuals are classified as general surgeons. So what struck us about looking at this data, and it applies across all the measures, is the significant variability that we see. And so the work group was charged with developing a threshold to identify the prescribers who, once their prescribing rate goes over this threshold, would be asked to do quality improvement with us. This measure has a threshold for the non-surgical providers. So non-surgical providers who have a prescribing rate over 8% in the future will be required to do quality improvement with us. There is not a threshold assigned to the surgical providers because the work group and all felt that prescribing opioids was much more part of their practice. Okay. And then moving on, this is the data we looked at for the percent of index opioid prescriptions that exceed the recommended dose in the guidelines. So here we're looking at, of all the index prescriptions that you wrote, how many exceeded 100 morphine milligram equivalents? And the groups that this dose applies to, again, are the medical specialties or the non-medical specialties, or non-surgical specialties. So once again, we took all the dentists who prescribed an index opioid prescription, And then for each dentist in that group, we calculated the percent of prescriptions that went over that 100 morphine milligram equivalents. And so here what you see is that in the two lowest quartiles, the median prescribing rate is 0. And then in the highest quartile, there's a significant jump where the median prescribing rate is 50%. So in that quartile, the median prescribing rate was that half of all patients who received an index opioid prescription received an index opioid prescription that was over the recommended dose. Again, you see somewhat similar data for the emergency medicine providers. And then for family medicine, you see prescribing rates that are much higher, where so many providers are prescribing all doses over 100 MME that the third and fourth quartiles are the same. So in this measure, the quality improvement threshold is 50%. So any individual dentist whose prescribing rate exceeds 50% would be required to do quality improvement. So this captures the top half of the fourth quartile. So we're really looking to identify the outliers and the high prescribers with these quality improvement thresholds. And then we have a similar measure for the surgical providers, same construct, where we looked at all the index opioid prescriptions and identified how many went over 200 MME. So for the oral and dental surgeons, you can see that, again, there's significant variability, and in the fourth quartile, the median prescribing rate was 80%. So again, here the quality improvement threshold is 50%. For this measure, that QI threshold captures the whole fourth quartile of providers in oral and dental surgery providers. Okay. If anyone has questions, we can go back to that. So as Dr. Schiff mentioned, and as we alluded to in the data, another portion of the OPIP is a quality improvement program. So this is applicable to providers who care for Medicaid enrollees. What will happen beginning in the winter of 2019 is that people will receive an individual prescribing report based on their data that will look at their prescribing compared to their anonymized peers, so the median prescribing rates of their specialty. The reports will be sent out electronically and will be confidential. The legislation, they're under peer protected review in the legislation, so this data cannot become public until we get to a point where we would disenroll a provider from the Medicaid program. We hope to never do that. We're bringing the opioid prescribing workers back together to identify the terms for that. And the quality improvement portion of this program won't begin until late 2019 or the second round of reports. One of the reasons that we're bringing the work group back together is to identify what the quality improvement review will look like so that this process is informed by the medical and dental community and has buy-in from all of the people who it may affect. And we are going to develop this quality improvement program in partnership with both the medical and the dental community. And we would ask for anyone's input on what this should look like, because it is going to impact quite a number of people. And the final portion of OPIP is the provider education. So there's a number of things that we're doing to provide education resources around the guidelines. We're working with the university. We have resources in partnership with the Minnesota Hospital Association, and then we have a provider education campaign called Flip the Script, and that will launch in the following months. And the goal of that is to provide consistent messaging and tips on talking to patients about opioid use. This slide has some of the resources that are available through the Department of Human Services. With that, I will turn it over to Dana.
I want to say that I was at the university here, taught in the School of Public Health, and then worked at Boynton Health Service, and been 5 years in state government at the health department. And I gained an experiential understanding of the word bureaucracy as part of that. But one of the highlights has been on this opioid prescribing work group, and Dr. Nadeau has been a great representative and champion for dentistry. So a public health approach, when we take a look at a public health approach, part of that is assessment, and we do have a lot of multi-state agency collaboration and data. So the Department of Human Services, the Board of Pharmacy, DHS is looking at treatment, we're looking at hospital data. So part of this, when we take a look at the opioid epidemic, is we're trying to gather data from multiple perspectives, including law enforcement. And so what is part of that is then what patterns do we see, what is shaping or sustaining these patterns? And the opioid prescribing work group spent many hours looking at the data, looking at those cutoff points, looking at the research. That group included not only representatives from dentistry, but again, multiple perspectives, Mayo Clinic, law enforcement, pain management. And I think one of the most influential members on that committee was the pain psychologist. And so as we take a look at that public health approach and gathering the data and then taking a look at policy and program development, part of that is reframing public, patient, and professional perceptions. And so as we looked at this, and as you think about your practice, how have you changed your perception about pain management, about wound management, about practicing? And a large part of this, as we all know, as we change our practice, is going through those sort of supports and developing the policies. And this is a lot of reframing how we do things. I think education is a two-way street, and so I want to learn a little bit from you all. How many of you felt like you have made significant changes in your prescribing practices in your clinic? Significant changes. How many think they've not made any changes whatsoever? I hope maybe not. And so part of this is there is change, and then as we go to making these protocols and policies, is that what's the assurance for a competent workforce? What are the enforcement of the protocols here? And so today is an example, the CMEs, new curriculum in dentistry, professional standards. You've gotten several different recommendations from your professional standards. Our state opioid prescribing work group, and then the insights not only from what people would be getting when they're enrolled with the managed care, but when you use the PMP, and how many of you use the PMP or have a delegate use that? Everybody. You're using that, the PMP, because it will make a difference, because one of the sort of startling incidences I've seen is where you have individuals contacting over 20, 30 dentists in a weekend. And so if you don't use that PMP, how many people have gotten a late night call Friday night, Saturday night, and that's what that role of the PMP is. Change is difficult in the practice. And so one of the things we have from a public health perspective that we're trying to do statewide, as Jeff alluded to, some of the things we're doing to address this opioid epidemic is St. Gabriel's Healthcare in Little Falls. We have a pilot project with 8 different pilot projects in communities where their practice is changing the prescribing and looking at how do they change their prescribing practices, how do they change people when they're on chronic opioid therapy and tapering. And part of that is an ECHO project where they get together. They talk about cases, they make recommendations, and it's that learning collaborative, whether you have it within your clinic or a broader group is helping deal with the difficult cases. And that's that opioid prevention pilot project. And then peer and clinic patient reviews. As Sarah said, there's quite a variability. So when you think about your clinic or your group, is there a variety of prescribing practices? And it's hard when you're as a peer, you know, this person has their authority, but sometimes people get into certain practices that may not be best. As Sarah mentioned before, some of the data about dentistry's intersection with opioids, this is from the from 2016, and I thought a visual might be helpful. And so when we take a look at dentists, within all the prescribing groups, they were the 5th highest prescribers of opioids in 2016. And so part of it is a lot of contribution there of opioids. But one of the things that I think Minnesota can stand out in much of our healthcare is dental association clinics, educators have made change. The U has been a leader in taking a look at, on the forefront of this, in making changes. So there needs to be kudos. And I hope everybody has become an early adapter of these changes. When we take a look, oh, this is supposed to be covered up, some should be animated there. But part of the safeguarding the dental practices is checking the PMP, is having a discussion about patient education. That patient education is about expectations, about not just pain management, but wound management. I'll have a story that I'll share with that Joe had that was an unfortunate outcome, but I had a positive outcome. My son, who's in high school, had his wisdom teeth taken out this last spring. And the oral surgeon had a great discussion about wound management and then also about pain management. And that the discussion was about using acetaminophen and Tylenol. And here's a prescription to the parents. If you don't need it, don't fill it. Try this first. And that's a much different discussion than maybe 15 years ago. You know, here's 15 pills and you know, you can have 15 more. A much different discussion, and we didn't have to fill it. And so that's one of the things that we're going to also be looking at. The Department of Health is working with the Board of Pharmacy and instituting some different softwares for better analysis. So one of the things is, you write a prescription, that's one thing, but is it filled? And so we're trying to look at some analysis where we can take a look at, you know, what's been filled and what's the number of people that are prescribers and are they using the PMP. And so again, Sarah mentioned this a little bit about the effectiveness, and this is from the Cochrane reviews. And what you can see here is the percent of people getting 50% pain relief. And so part of that discussion with the patient is, yeah, try this, see if it works. And quite often, if you can see over here on the left, 5 milligram Percocet pills, 35%. Ibuprofen, 200 milligrams, again, that range. Ibuprofen alone. Oxycodone. And there's the example where often that the opioids may not be the preferred approach to acute management, acetaminophen, and then it was that combination that over 60% got some pain relief. So I thought that visual might be helpful at 6, 7 o'clock in the morning. So our dashboard. One of the things as a interstate or interagency collaboration, the Department of Health has a grant from the CDC called a Data-Driven Prevention Initiative. And part of this was bringing people together, our stakeholders, our colleagues, and developing this opioid dashboard. If you just went Minnesota opioid dashboard, it would probably come to this site here. It's easier for me to go to Google and look for it than within my own agency's search engine. So part of this is that the indicators that we have here, overdose death, non-fatal, misuse, prescribing practices, and it's under this prescribing practices here that we have information about practices, about even some of the information from the PNP on dentists and diversion. When we take a look at then the dashboard, it provides up-to-date data on a variety of indicators, links to numerous information, and that you will have some information then what's improving, what's getting worse. You can sign up for updates up there on the right. and that each of these sections, there are 7 sections, overdose death, non-fatal, misuse, prescribing practices, supply diversion, social determinants. I'm going to make my public health plug here. How many dentists do we have in the room? You are well educated. You are thoughtful. I don't know how many of you are involved in your communities in this issue, but you have a good rational voice, and we need all the professionals on board. And so when the residents come through the health department, I also talk to them about being involved some way in this issue if you can. We're all busy professionals, but you bring a great voice. And each one of these indicators can be expanded. And so each indicator has tabs, and that's where we take a look at some of the in-depth analysis, the data, the strengths and the weaknesses. We'll be looking at them, just as you saw the cool maps about the prescribing by county. We have a variety of those, and then taking a look at what might be some toolkits. We just released an employer toolkit about opioids. So you're not only a professional practice, but you also have employees. And so there is a role there. And so you have a role as a provider, an employer, and a member, a citizen of the community. And so as we get to the end here and leave time for questions, especially those improvement programs, maybe Jeff and Sarah and I can all chime in together. What we're doing as a state, we're having mini grants from the federal government, some state funds, and what we're looking at, a lot of the emphasis has been on treatment and recovery. And part of what I've heard, not just anecdotally, but there's some indication, and as what Sarah said there, is that discussion about acute pain management with people who are in recovery as a challenge. And so one of the things about changing not just prescribing practice, but how you interact with patients is sometimes getting into those discussions that are getting other information about their status and whether or not that they should be getting an opioid. Law enforcement, incarceration systems, one of the things we see is that, unfortunately, addiction hijacks people's brains, and we see a lot, and then it's not just also the addiction, but as you saw in the slides, the high rate of mental illness and mental health problems, and we're trying to, I want to say, divert people from the big house into better treatment, mental health, recovery, and break that cycle. Part of what you see in Minneapolis at that homeless encampment is some fallout from some of these things. And so when people have felonies, it's hard for them to move forward. Emergency response, we're providing naloxone to first responders. We're providing naloxone and DHS to community groups. And I don't know if that would be something that clinics would think about. Okay, do I have naloxone here? Not every patient is forthcoming about what's in their system, and so that might be something that you consider about who's trained in your clinic, either from a professional use or personal. What's happening in your neighborhood. Prevention. We're trying to move more upstream. These policies and procedures you heard is about trying to reduce the development of chronic users. And it starts with that first pill for some people. I'm sure that all of you have stories about how that person who was naive, it changed the way, especially for adolescents. It's the psychology of intoxication. It's the psychology and chemistry of pain relief. So as we look at pain management and looking at how do we manage pain, it changes the way we're doing things and trying to move upstream there, and looking at some of those other determinants. I think we are ready to stand for some questions. I believe we got about 5 minutes or so. And now